Well, thank you, everyone. I very much appreciate the opportunity to join you today. It's very nice to visit. Absolutely lovely institution and a very vibrant group in medical ethics here. As Dr. Dukas introduced, one of my other interests, or one of the other hats, many of us, I think, wear some of these different hats, is directing a program for Japanese patients. And a lot of my entree into medical ethics was through differences in cultures and looking at how values are being very different in Japan and the United States, even though they're both very technologically advanced societies. And that actually relates to the slides that I have today. You'll see the cat in the bottom corner, which is called the Maneki Neko, which means the welcoming kitty. And many of you are probably familiar with Hello Kitty, and I don't know if Hello Kitty may have morphed from Maneki Neko because cats are loved in Japan. But the Maneki Neko is usually a statue is posted at doors in front of establishments where you might want to go in and eat or buy something, welcoming you in. And so I chose this symbolically to welcome your questions, and so that we may have a dialogue. I certainly don't want this to be a one-way avenue in terms of what we're talking about today. And it is a great privilege to be invited to give the Gaines Lecture today. I should acknowledge my collaborator in this, Susan Gould, who some of you may know is director of the ethics program at the University of Michigan. And for this project, we had the support of our deans, Joe Fantone and Casey White. So I thought it would be valuable to take some time today to think about how is it that we're teaching ethics and professionalism, and we'll use what we learned through a survey of our course and clerkship directors at the University of Michigan. So objectives being to review a recent survey of the course and clerkship directors about what ethics and professionalism topics are taught to our students, and then to really talk broadly about what you're doing here and, with regards to how medical ethics and professionalism are taught, and how do we evaluate whether or not that's been effective. So I think largely we can all agree that there's a great importance to the teaching of medical students learning about medical ethics and professionalism. But the controversy seems to still remain about what are the most effective ways to teach it in a medical school curriculum. And there's a very large body of literature about the hidden curriculum, do what I do, not what I say, which we won't probably go into extensively, but we should really recognize that. And just one example of some of that research by one of my colleagues at the University of Michigan is by David Stern. But what we didn't really know, at least at Michigan, and maybe you have a better handle of this, that here in Louisville, is not much was really known about what and when how medical ethics and professionalism was being taught in our own courses and during our clerkships. So we endeavored to try and learn a little bit more about that, and I think it was pretty interesting. So we'll go through that. So we do have a nice medical ethics program at the University of Michigan now, and it's been growing pretty well in its reputation nationally, but it's been largely more in the research realm than in our ability to really penetrate and stay in the curriculum and for the teaching. And so that's part of what drove us to take a look at this. And so it was our task to increase our activity and presence. And this was all in the face of a decrease in the amount of time available for us to teach medical ethics in the curriculum. And part of that was a restructuring so that our second-year students could finish earlier in their second year and have more options to get involved in research, because the University of Michigan is very focused on students who want to pursue careers in research. And also it does create opportunities for people to do earlier electives if they want to go into some sort of specialty training, subspecialty training. So the new idea was that ethics was being rolled into the other rotations rather than having it in explicit time dedicated to medical ethics. And there's certainly an argument for saying ethics should be applied and that when you talk about medical ethics in a context, it becomes easier. And in particular, in our institution, we developed something called the family-centered experience, which I'll tell you a little bit more about. So again, the University of Michigan is a very large institution. There are multiple courses and rotations, probably not significantly different from what you have here at Louisville, but it's not really transparent when and how medical ethics is being taught. There are, of course, as are here, not as many, but there are explicit formal lecture in the undergraduate curriculum, and it's mostly in the first and second years, and typically we know something about what the quality of those and at least what the students' perceptions are about how valuable they are. But therein, again, is this hidden curriculum during the third and fourth years. So we identified a couple of research questions, which are what are the most important medical ethics and professionalism topics that should be taught to the medical students. In other words, as a faculty, we needed to come to some agreement about what should be taught given this limited curriculum time, and then to say, well, to what degree are those topics actually being taught to students during their undergraduate education? So in the overall design of this project, first we did a review of what's called the family-centered experience by bioethics faculty, and then among the group of bioethicists at the university, and I say that in a rather eclectic way, including the educators invested in medical humanities and professionalism, to get everyone's input about what's the range of everything that could be taught, and then winnow that down to say, then what is being taught actually. And that involved a survey of course and clerkship directors about medical ethics and professionalism topics, as well as qualitative interviews with selected participants. So I'm going to just tell you a little bit, take about 5 or so slides to talk about the family-centered experience. And I put this up to illustrate sort of the overarching goals of medical training as they're perceived by the institution, being the teaching of the actual knowledge of medicine, the basics, clinical skills, and then communication skills and compassion. And this new program, the family-centered experience, developed around the teaching of communication skills and compassion, and that this would lead to the best practice of medicine. So this is how the experience is set up. It's a 2-year required course. It occurs longitudinally during the first and second years, and pairs of students are matched with volunteer patient families for discussions of their experiences with chronic or some sort of serious illness. And then the goal is for the student to see the illness and medical care through the eyes of the patient. So as we frequently distinguish in medicine, there's the disease, which is the medical understanding of an abnormal process, versus illness, which is the subjective experience felt and experienced by the patient. So this is about trying to get students to at least understand a little bit more about the illness aspect. And the goal is to use illness narratives to explore the world of illness and to teach patient-centered humanistic medical care. And it's meant to complement the training that they were getting in their biomedical sciences. So what happens is in the M1 year, they have an initial visit in September with the family members, the second visit in October to November, and the third visit in January. And these visits are assigned to a dedicated topic. For example, illness, what's the impact on self and the family? The second visit being about patients and physicians. Third visit about breaking bad news. And then they actually go with the patient to one of their doctor's visits and see the visit from the eyes of the patient, having got to know the patient personally. And then in their second year, they have a fourth visit, which addresses stigma, a fifth visit doing family's choice. What is it that the family wants to talk about? And then their last visit is, what did we get out of this at the end? What were sort of the lessons for you, for me, that they talk about with the family? So, and the interesting thing is that there are these small group discussions. Following each home visit, they meet in small groups to talk about the particular theme, and these are led by the students. And then not do they just go, but there is actually preparation involved for these, including an orientation lecture which involves students getting preparatory readings and a review of guidelines and questions that they might ask and pose, actually doing the home visit, and then further preparation through assignments and readings to discuss about the case in their small group discussions. So the clinic visit is quite interesting. It is scheduled according to family's clinic schedule and occurs sometime between August and early April of the first year. And it's really about seeing medicine from the other end of the stethoscope. They have to complete a form about the visit beforehand, and then they debrief after the visit. The other unique aspect of this experience is an interpretive project. And during the winter term of their first year, students work in pairs, so they represent two different families, and they develop some sort of project that represents some aspect of their experience in the illness or its care. And they're actually allowed to use any sort of medium that they would like to express their understanding about what illness means to them. So coming back to our project, we felt since this was a new significant component of the curriculum that it was necessary to review this project to see, well, since this was, covering now part of the ethics curriculum, how in fact did it cover the ethics curriculum, and what were the explicit, implicit, and potential ethics topics that could be covered during this very large and resource-intensive experience for the students. So there were 10 cases and 3 seminars reviewed, and these are some of the folks that reviewed those. And indeed, there were some very good topics being covered. For example, there was a longitudinal case on dementia with explicit attention to confidentiality, truth-telling, genetic testing, and breaking bad news. In addition, there was another case that involved a reproductive sequence with explicit focus on cultural diversity, and there were other implicit topics relating to trust and potential to draw attention to professional limitations, honor code, and dealing with uncertainty. So this was the new curriculum that was added in, and now we wanted to say, okay, we know what this quantity is. We got a little better handle on this now. What now do we as the bioethics educators feel broadly are the range of topics that could be taught, and now how do we winnow that down to what should be taught, given that there are in fact limitations for the amount of time that you're going to have with students? So that involved defining the breadth of topics, an assessment about what should be taught, and here we use an important criterion, which is what should a graduating medical student be competent to perform as a PGY1 resident? And part of this reflecting the new emphasis and interest on competencies. And so in these, in our comprehensive assessment, we weren't interested in knowledge areas because especially medical students are very applied to what is their clinical work, what do they have to do, and we felt that if we framed it as competencies, skills, that there would be more interest in, that being a focus of the work that we were doing. And again, there are many things that we could cover in the area of bioethics, but what do they really need to know when they finish medical school? What are the sort of ethical skills that we want them to have when they finish medical school so they can at least go out and be a ethical house officer when they first start their time as doctors in hospitals and their residencies. So what we did with this very large list of topics that was generated was make a ranking of the list with essential, strongly recommended, and recommended topics. So this led to a master list of medical ethics and professionalism knowledge, attitudes, goals, and skills. And for example, with regards to consent, it received 15 different ratings from bioethics faculty, 7 saying it was essential, 4 saying it was strongly recommended, and 4 who said it was only recommended. And then if the topic wasn't at least listed as essential, we didn't include it in our survey of course directors. And each of the content areas was framed as a skill. So again, what we've done is we got the relevant educators of medical ethics together. We said, first of all, what are the things that our students really ought to learn or that we could teach them. Then we winnowed down the list to the things that, yeah, this would be really good if they were exposed to this, or I strongly would recommend this, or this is really essential. And the things that everyone pretty much said, these are really essential things, we said, okay, now we're going to talk to the directors of the different courses and say, are you teaching any of these things? So that we could get a sense of, here's the ethics faculty saying these are things we think are essential for all our students to know, and then finding out, are these things actually being taught in the medical school? Does that make sense? Okay, so that led to our third phase, which was the survey of the course and clerkship directors. And we administered this over the web. And to get our response rates boosted, we worked through the dean's office. You know, it looks better coming from the dean than from someone who's in the bioethics department who everyone knows is enthusiastic about teaching bioethics, right? So trying to leverage our strengths through our senior people. And we did send out repeat email requests ×2, kind of standard survey methodology. Yes?
Did you survey basic science course directors, and did you have much expectation that they would cover these topics?
We did, and I'll show you who all was surveyed in a moment. Yep, good question. So our eligible participants were a total of 50. And these are the just the sequences that the students have, and then an equivalent director for these was found. So patients and population, cells and tissues, clinical foundations. I mean, I suspect there's probably a fairly similar list of topics that you all teach here in Louisville as well. So that's in their first year. And you see down here on this list is professionalism and the family-centered experience. And then the second year sequence, again, more applied clinical medicine kind of topics. Again, not probably much, it's probably much like what you teach here. And then the third year sequence, again, with the clinical rotations among those family medicine, internal medicine, neurology, OBGYN, pediatrics, psychiatry, surgery, and then their M4 sequence, which includes emergency medicine and advanced medical therapeutics. There are, of course, many electives that students take during their fourth year as well. They weren't really required clerkships there. So these are the actual results, and what we got back, this is illustrating what year of the curriculum for which the director had responsibility. So if they were in charge of the first year curriculum, the response rate was 9. For someone who was in charge of a second year course or clerkship, it was 7. For third year, 4. And for fourth year, 5. And one person didn't really tell us which year they were in charge of. Maybe they were in charge of several years or something. But that gave us overall response rate of about half, 52%, just over half of all the clerkship directors responded. And that's with a couple of emails. So in and of itself, it tells you a little bit about who's willing to complete a survey like this. It's probably those who are most enthusiastic about the teaching of medical ethics. And then this tells us whether the particular course or clerkship that they were in charge of was a requirement or an elective. And you see that most of them were actually about a required topic. So I forget exactly how many it is offhand, but there were approximately 40 or so topics that we as bioethics faculty thought were essential for students to be exposed to during their medical education. So we don't nearly have the time to go into what each of those would be, though it might be interesting to see if there's been any discussion here about, well, what are the things that we want to make sure every single student that goes through Louisville, when they graduate, they've developed at least some exposure or some competency in this area, so that we feel as an institution that when our students leave, we can confidently say that they have this set amount of competency or skills. So at any rate, this one was about what is your commitment to treating patients, is on your rotation, what is the teaching? Is there teaching for a commitment to treating patients in a non-judgmental manner regardless of race, gender, religion, sexual orientation, or other personal characteristics. So among all of those who responded, 11 of the directors of their course or clerkship said that there was in their curriculum, if a student rotated through, routinely a student would be exposed to this kind of ethical value and a skill. We consider this a skill. A commitment to treating is a skill. Perhaps that's a stretch. But quite a few of them thought that it was routinely taught, and this was the one that was cited most highly as being taught. And down here, what we actually have is the specific sequence in which it was being taught. And it's kind of interesting coming back to the question, were the basic scientists included in this or not? And yeah, so here a number of basic scientists said that this was something that they were making sure that students were routinely being exposed to. And then coming up again in some of the clinical rotations, M3, surgery, psychiatry, neurology, etc. So what I've done now is to provide for you, these are the actual skills, the ethical skills that we provided to the clerkship directors and said, are these routinely taught in your rotations? And so you can see that 11 of the courses clerkship directors said that there was a commitment to treating patients in a non-judgmental manner, as illustrated on the slide. And then these were the other things, as you'll see, in decreasing order in terms of the frequency by which clerkship course directors said that they were actually being taught to students. So commitment to privacy of the patient, commitment to involving patients in clinical decisions, recognizing potential breaches of confidentiality, understanding ethical rationale for honesty and forthrightness, and probably not very valuable for me to read all of them. Well, I guess we're being televised, so maybe I should. Understand accountability students have to patients, to themselves, their peers, and teams. And then 6 of the directors said that there was teaching consistently and routinely about assessing decision-making, taking measures to avoid confidentiality breach, and self-monitoring own behavior. And then we get into ones where they're less consistently and routinely taught in the clerkships. Prudent use of healthcare resources, appropriately balancing demands of educational and personal needs, and commitment to caring well for dying patients. So this is about approximately a fifth of the respondents saying, yeah, this is something that we routinely teach about. And then it starts getting a little thinner. Obtaining valid consent for clinical care, recognizing and accommodating religious and cultural beliefs, understanding how U.S. health system financing and organization influences care, which was a little higher than I might have expected, discussing economic aspects, protecting patients from inappropriate physical, sexual, or verbal abuse, choosing which behaviors to actually emulate in teachers and peers, and recognizing sexual contact with patients and staff as unethical, recognizing drug and alcohol abuse in others and self. And then some of the topics that least commonly taught, again, it's kind of a long list because we asked about a number of topics. But we're seeing now that some issues that faculty consider to be absolutely essential for students' education are being routinely taught in a relatively small number of places. So approach to patient who's unable to fully participate in decisions, recognizing when hospice or palliative care could be appropriate, discerning differences in advanced directives, living will, durable power of attorney, a topic close to Dr. Duca's heart, recognizing the role of economic and policy factors, how to competently break bad news. This is something that perhaps we might like to see in more of the rotations. Identifying justable exceptions to protecting patient confidentiality, disclosing medical errors, distinguishing between medical errors and adverse events, recognizing potential boundary issues between patients, staff, physician, a commitment to community service or public health. And then there were several issues, as we note here, where only one group, one of the respondents said that it was routinely taught during their course or clerkship. Obtaining valid consent for a refusal of care. appropriately responding to a request for physician-assisted suicide or euthanasia, discerning between effects of doctor reimbursement on clinical decisions, recognizing unethical behavior by peers, or distinguishing between coma, PBS, and death by neurological criteria. And then none of the respondents said that there was any teaching around recognizing conflict of interest, understanding purpose, structure, and function of institutional ethics committees, recognizing when a consultation with an ethics committee would be appropriate, or how to appropriately interact with a pharmaceutical or a medical device manufacturer. So these last three slides illustrate both the topics that the faculty deemed as being absolutely essential for any medical student's education, and then how frequently those who are in charge of those courses and clerkship said, we think these things are routinely taught. Because we know a lot of these things come up randomly. I mean, it's just inevitable that these issues will come up in a random way, but as educators, especially from the dean's level or as from the director of a medical ethics program, we would like to know that people are systematically exposed to some things that we think are really critical. So that's the value of this piece, I think. So what we learned from this was that, in fact, who are our most active partners in ethics and professionalism teaching? Because at some level, at least in our institution, I think we'd like to have everyone on board, but not everyone's going to have the same level of enthusiasm for the teaching of medical ethics, professionalism, humanities, say, that we do. So who are the most important partners for us? And that was indeed the family-centered experience. And so where there had been some time lost to the medical ethics faculty because of this new experience, it does seem as though there was an incremental gain there, or at least a balancing. Second was psychiatry, where there's a lot of issues that come up around boundary and what are the legitimate issues of the state compared to the individual, how does autonomy get adjusted for psychiatric illness, and emergency medicine also being an area where there's a lot of active ethical problems, as one might expect. And also we found in the endocrine sequence in the second year, there was a particular faculty member, not so much due to the content area, but because of the faculty member's personal interest and commitment to ethics, that there was a lot of emphasis placed there. We did do follow-up interviews with the clerkship directors who seemed to be most enthusiastic about their teaching, to say, what is it that you're doing? And that included 2 from the emergency department, 1 from psychiatry, 1 from the neurosciences sequence, 1 from ophthalmology, and 1 from ENT. And I will note that of these, the ophthalmology and ENT are both elective rotations, so that a student wouldn't systematically be expected to be exposed to what they were being taught on those clerkships. But we thought it would be interesting to have both of those views. And basically, among those, that core group that were most enthusiastic and most active, they said, it's hard to have explicit teaching about ethics in our clerkships, and that students tend to resist attempts to do the didactic talks, and that basically there's a belief that role modeling is the way that it happens, i.e. the hidden curriculum. And their view was that the most important mechanism to improve medical ethics teaching would be investing further in faculty development for select faculty members and also residents, to get the residents involved more in the teaching of students. And I'll come to that a little bit more in a second. So here's what one of those faculty members said: all care is teaching by role model, good, bad, or indifferent. Most students identify with a resident. One resident hates drug abuse, does not like alcoholics. Students see that, and attendings try, at least sometimes, to address that resident attitude, but not always. So here you see the negative impact of behaviors in a resident and how that can adversely affect the ethics teaching of a medical student. And then in terms of our discussion with psychiatry, we said, well, what would be really good issues to just assume consistently will be taught in psychiatry? Can you guys always teach your students? And these came out to the boundary issues because there's a lot of relationship building in psychiatry and a lot of trust issues. And so the boundary issues become really important. Issues when patient decision-making capacity is compromised, medical decision-making under impaired autonomy, issues regarding medical power of attorney, or when the interest of state outweighs individual being able to look out for their own interests. And then in the emergency room, we said what would be your most appropriate topics? Informed consent. There's lots of procedures going on, lots of opportunities for consent to happen. Assessing competence. This is something that ER docs, they don't really have a relationship usually with patients coming in. They have to make some assessment about what's the competence levels. And also withdrawing of care and end-of-life care. Though interestingly, they don't feel that students would be in a position to lead discussions about end-of-life care, commenting rather that these are the sorts of things you might expect a third-year resident to address. So it does bring back to bear again, what are the things that we want to make sure that we emphasize and use our resources for teaching students about, and then where are these things happening? And there may be other things that they're exposed to which might be sort of prepping them for what they're going to learn as residents, maybe as fellows, and just sort of defining that beast. And this director of the ER rotation talked how she had a sort of set talk about abuse and how she dealt with it. And she said students just weren't engaged, that she had a hard time engaging students around that kind of discussion. So what we found in our evaluation of how we're doing things is that things that are being covered well involve, physicians and physicians teaching students and students developing a non-judgmental approach to their patients, to protecting privacy and confidentiality, to involving patients in decision-making, learning about honesty and forthrightness, being accountable to patients, self, and others, and assessment of decision-making capacity. Things that we thought were adequately covered in a fairly consistent way were prudent use of resources, professional balance, commitment to dying, obtaining consent, accommodating sociocultural differences, health financing and influence on care, harassment, role models, and substance abuse. And then things that were really kind of marginally covered, being impaired decision-making, decisions about when to use hospice or palliative care, advanced care planning, breaking bad news, what are exceptions to patient confidentiality, medical errors and adverse events, boundary issues, and community service. So then this actually includes a list of things that are not routinely covered at all. Refusal of care, conflict of interest, recognizing unethical behavior in others. Brain death criteria actually is covered in one. That's an error. And also the role and use of ethics committees. So, of course, we did only have slightly over half of the clerkship course directors respond, so there were 24 who did not respond. So it is quite possible that some of these topics are covered more in some of those other areas, though also we tend to think that those people who are most invested in the teaching of medical ethics probably would have responded and told us if they were doing these things or not. There was really no ability for us to make any kind of assessment about how accurate their statements were about what the quality of the teaching or the quality of the learning was for the students in those clerkships. And then the issue is if we have all this range of materials that really range of skills and knowledge and attitudes that really need to be taught to students, how can you leverage a small number of bioethics faculty time to really do that? So this leads a point to the talk where we want to use the Maneki Neko, the inviting cat, and invite more discussion from you as a group. I'm very interested in learning more about what your perceptions are about who should teach bioethics and professionalism, how should it be taught, and how do educators really evaluate the effectiveness of what is being taught. Currently, our curriculum overall is more and more moving towards a competency-based curriculum. And so I think it does push us to say, as educators, how do we then assess competence in ethical decision making or ethical approaches? And that's where I'd like to put the cat out there and see what your questions are. Yeah.
I take it then that in the evaluation process, you don't go back and try to cross-examine in terms of issues, say, for instance, on non-judgmentalism.
Mm-hmm.
You kind of take their word for whether or not it's non-judgmental.
Right.
It occurs to me that one of the problems that we have is, just for example, with regard to abortion, is that a lot of people think they deal with women even-handedly and non-judgmentally, but if she should decide to terminate the pregnancy, that's when the other side comes in.
Mm-hmm.
And either implicitly or verbally, a strong point of view is represented. So does that dissonance register also on the campus at UM?
And so I don't know if everyone was able to hear the question. The question being related to this topic of assessing and treating patients in a non-judgmental way, and then bringing in the issue of abortion. And so even though people say it's being done in a non-judgmental way, could it perhaps not really being done in a non-judgmental way? If a woman elects to keep a pregnancy, yes, we would be supportive and non-judgmental, but if she elects to have an abortion, that then we might become more judgmental. And as you point out, we weren't really able to assess that. I mean, one of the problems doing something like this is the limitation of resources and feasibility, and so to actually talk to everybody is one thing. We thought we did a fairly good job to at least try and get people's input in a way that was feasible, and we got about half. So, that at some level that says, well, all right, well, where are we at? We're going through the dean's office. We're asking people to participate, and so you don't really know. But my personal opinion is that there very much is a problem, as I think you're implying, that often it's not done in a non-judgmental way, and I think that's the sort of thing that's really hard to assess. Do you have any suggestions for how we might teach how to have a non-judgmental attitude towards, because I think it can be modeled, for sure. I think we would all say it can be modeled, and if we believe in the hidden curriculum that these sorts of things ought to be modeled well, that do as I do, not as I say, that it would be really imperative for us to find people that we think role model that well, and then categorically expose our students to that handful of people that are doing that, or whoever we think does a good job of it. So therein comes the issue of logistics. Bioethics faculty may not even be seeing patients or a woman who's making a decision about whether or not to have an abortion. So there we need to have, particular faculty members working with students, or rotations where students are going to be exposed to someone that we really feel can do that in a non-judgmental way. So there are a lot of practical issues involved in that. There's a hand over here. Yeah.
There you go. Considering how low self-monitoring, own behavior, and making critical assessments of decision skills, if you start bumping those up, you'll probably see an impact on being fair and non-judgmental on both sides, because you're increasing that reflectivity.
Right.
Right? So it seems like you have in your critical list, you have things that feed on each other. You have complementary competencies.
Mm-hmm. Mm-hmm.
Okay, so you may have some benefit out of, as you continue to work on all of them, you'll start seeing sort of that synergistic responses.
Yeah. So the comment being that if there was more attempt to raise the self-monitoring, that people would develop their own sort of frameworks and reflection about what they're doing, and that might enhance the other areas. And I think that's a very good point, that if we have a limited amount of resource, that we really need to do some targeting of our resources in ways that will be most effective, and that's likely to be a good one.
Kind of on that relation, if anybody involved in this had background in Six Sigma or Lean or any sort of standardized process improvement, because this really does look a lot like that kind of project where let's see if we can figure out what the critical variables are and how we can most efficiently tweak those variables, because we can't actually find or measure. It's difficult and complicated, the end result that we're looking for. But if we find some sort of the simpler variables that we can tweak, then maybe we'll be able to see a greater effect.
Yeah. That was indeed the thinking. Really, is that you're drawing parallels to is lean, I believe, right? That wasn't explicitly what we're doing, but conceptually, that's exactly what we were doing. Yeah. So I think the next hand was yours. Yeah.
I've fielded enough questions from students who have concerns about things that they see residents or even faculty doing, and I get the sense that they don't always see it as a safe topic to bring up or know who to ask.
Mm-hmm.
And I think that one way of bringing those things up to help students do better is make sure they feel comfortable talking about it, and that if they bring up the fact that, I really just can't stand dealing with alcoholics and I don't know how to do that appropriately, then if they bring it up, they know it's not going to come back to haunt them on an evaluation, and they can talk about it reasonably and have it not be taboo. So I don't know if you all share that particular problem, but I think that's part of our hidden curriculum here.
Yeah, I think you're absolutely right. The question being, would students actually feel like it's safe to talk about things that they observe that they don't like? For example, someone being an alcoholic, they don't like alcoholics, and how would you actually talk about that? And I think your point raises this whole issue in terms of the power relationships that exist between students and residents and faculty members, and that if you get branded as ethics troublemaker or something like that, it can haunt you. And so how to develop a culture of teaching that reinforces this idea that people can talk about these things, I think, is really critical. I will say that the family-centered experience, which has a lot of small group discussion about not just ethics issues, I mean, it's about life and perspectives from patients, it's about illness, but these issues come up, that the students, since that curriculum started, have been far more comfortable talking about what they're feeling, what they're seeing, what they're hearing. And it really was, from my perspective as a teacher in the clinics, a fairly noticeable difference, that the students seem to be more mature in terms of their ability to talk about these things and observe them. So I think in that sense, the family-centered experience and the small group discussions where students are encouraged to talk more about difficult issues has led them to feel more comfortable about talking at least among themselves and perhaps with faculty and residents. But again, it's the challenge: how do we overcome the power differentials that exist so that people can really feel that it's a safe environment to talk about those things? A very good point. Yeah. And I lost track. I think it was in the back. Yeah.
Congratulations, University of Michigan got their CTSA grant. I think that's really great.
Thank you very much.
But in that grant, there's a lot of regulatory, a lot of ethics, and a lot of other things. And looking at that, do not cover. That's in there. So if you're addressing that already with whether it be researchers or clinicians, or because it has a lot to do with clinicians, it looks like those same individuals can be used to do the medical education.
Yeah, I think it's certainly possible when it comes down to, leadership saying, that we want to talk more about research issues and potential conflicts of interest and all of that. I think you're absolutely right. A very good point. Yep. Yes.
Extending a little bit this concept of impartiality, I noticed several areas here which would relate to older patients that really don't seem to be interesting to anybody, like hospice and palliative care,
Mm-hmm.
and like abuse and neglect.
Mm-hmm.
If somebody came in beaten up by a stranger, they would treat them differently than an older person who was beaten up probably by a family member.
Right.
And as the population ages, people are going to have to be a little more aware of the issues concerning the elderly.
Right. So the point being raised that there wasn't a lot here addressing teaching around geriatric specifics ethics. or the emphasis,
things that appeal,
right.
Apply more likely to older patients
Right.
that were not of interest.
Yeah. Mm-hmm.
Which means then that they're not going to get the care, appropriate care.
Right, and so, yeah, the where this led us to was to say what we really need to do is to look more at integration, rather than having the ethics talk about care of geriatrics patients, to try and maybe work more closely with geriatrics faculty to make sure that there's consistent inclusion in their talk about other sorts of issues to also address ethical issues relating to geriatrics. So, trying to get more applied teaching of bioethics, teaching the teachers more about the issues. I don't disagree with you at all. I think it's an issue that's absolutely important. And part of the issue, again, comes back to, I don't know, I think it's a controversy. Students on ethics lectures, generally, they don't show up unless they're required to. They're not tested on the content of ethics lectures. So at some level, you might say they're not as effective maybe as other teaching mechanisms could be. So it pushes us then to say, all right, how do we do a better job of getting the message across? And so I guess what we're trying to do, because we had a change in the structure of our curriculum to where our students are trying to graduate, where they're getting our students out of their basic sequences sooner, so that the students have more time for selectives and subspecialty areas or doing specific research topics. And because of that pressure, there is less time for didactics teaching in medical ethics. And so we're trying to think creatively now about, well, maybe if those vehicles weren't working as well, at least our students weren't very receptive to them, are there new ways that we can do that? And so I think what that means is for us to do an effective job of teaching around the issues, the ethical issues involving elderly patients, is we have to make sure that when students are exposed to the geriatric types topics, real time, clinically, that there's some systematic education to them at that point about ethical issues. Does that make sense?
Or could you include geriatric patients in your family-centered program?
Many of them are, because all the patients in the family-centered experience have chronic or serious illnesses. So many of them actually are. So that's the good news.
Can I respond a little bit to this?
Please.
I am the course director for perioperative medicine and anesthesiology, so we're usually in the middle when someone comes in injured or whatever. I do a couple things. One of my course objectives is, if something's not right, speak up. And they ask me, what the heck is this?
Right.
How am I going to prove on the final exam, where am I going to get my 2% on this one? And I say, you'll see. We come in very quickly, meet the patient, medicate them. They don't get a chance to ask the question. That's wrong. Speak up. Get informed consent over and over and over again, because that is an evolution, particularly with seniors. I'm a neuroanesthesiologist, so people with issues, with brain issues, you've really got to, or ICU psychosis, you've really got to go through the evolution of the consent, the evolution of informed consent. And the other thing I do, and I don't call it ethics, is I have a case. It's a geriatric case, little old lady, independent living. I make them play act. Somebody's clergy, somebody's lawyer, somebody's a daughter that agrees grandma should be cared for fully. Another one's a daughter that says, stop, grandma's had a good life, she's been independent. We deal with the transition from independence to dependence, possibly permanently. We deal with altered mental status and sudden incapacity to make decisions, and who should be the decision maker. The orthopedist needs to fix the bones, so grandma doesn't get pneumonia. The cardiologist said, no, she's having an MI. The neurologist said, no, she's having a stroke. So, these kinds of case discussions and giving the students permission to speak up, and they get very emotional, because everybody knows this case. Either Aunt Susie or Grandma.
Right.
And I have found it very effective for the ones that participate. If they catch on
you're talking ethics, they're not there.
Yeah.
I agree with that.
So the hidden curriculum in the good way. So your
It's a
point.
really good thing.
So if I understood correctly, you're the director for the neurosurgical anesthesia. Anesthesiology rotation, right? So you would be an example one of our champions in our survey, and had we done this study here, we would have been interviewing you to say, how are you doing it? So
I also have to give credit to my husband, who after 17 years of being a cardiovascular physiologist, internist, cardiologist, went back into geriatrics to address some of these issues.
Yeah.
So there's a
So
culture.
that's good, and you wonder about how prepared are students to take on the material, and so I think your sort of stealth approach, meaning first of all not calling it ethics so you don't all get the willies in the first place, and also then picking a case that they can relate to personally, something that's happened to either their grandmother or their great aunt or somewhere in that realm, because many of the students, if they've gone straight through, they may not have really, experienced any significant sort of difficulties. So that's, I think, a very valid point. The other one is you raise the issue of role plays, and I'd be curious what people think about that. My experience with role plays is that when they go well, and you sometimes get the person who sat in the corner through their science class for 4 years and got great grades, and generally I think our institution does a pretty good job for picking people that are balanced, but you do still get folks that just really aren't willing to engage in that way. And so certainly I think there's a great place for role plays. The question is, are there other things that we can do to engage those who maybe don't respond as well to that particular technique, taking into consideration that people probably have very different learning styles, and they may even be changing more now that technology is changing. There's the whole Nintendo generation that's coming along, and what's going to meet their educational needs. Certainly very different from what it was like for me, I think. And question back here?
One thing that I feel is helpful to students is to distinguish the difference between being an ethical person and discussing medical ethics, and helping them understand that you can be an ethical person with good intentions and still make medical ethics mistakes. And I think the self-monitoring is one of the keys here, and modeling for them when you catch yourself doing something in a less than ideal way, and helping them understand, I just came out of that patient's room and I realized I said something I really shouldn't have said, and I wish I wouldn't have, and next time I need not to. And I think those types of case-based ways of integrating these concepts are helpful for them to understand that, yes, medical ethics is something we deal with every single time we talk to a patient.
Yeah.
And just kind of reframing medical ethics for them and what that really means.
So again, your new point is about helping students distinguish between being an ethical person and how that can still lead to medical ethics pitfalls,
In other words, I think
even if you're trying to be an ethical person. And
right. I think one reason students may not want to engage in ethics conversations is they think, well, I'm an ethical person, I don't need to talk about this.
Yep.
And that's not exactly what we're talking about.
Yeah, that's certainly been our experience, that students come in feeling as though they're good people, they're ethical people, they're very, righteous, they have good motives, and that's going to lead them down an ethical course. And so I think that's a point very well taken. And again, the point on self-reflection is a very good one. I was just thinking how many times, I'm not sure that I ever have walked out of the room when I had a student with me and said, I don't think I did that as well as I could have, maybe a few times. And I think...
Some of my best teachers were the ones who did.
Yeah,
Think about how
because
powerful
it's...
it would be if your teacher said, you know what, I didn't do something exactly right there.
Right.
You can go back in and apologize to that patient for saying that.
Yeah.
That's the kind of thing that would stick with you.
Yeah, I think it definitely would. I think it kind of caught me on the fly here thing. So I think that's there, and I think it would also illustrate the vulnerability and the imperfectibility of being a physician, and how does one best role model for students. So how do you teach attendings to walk out of the room and say, I screwed up.
Start by modeling. And your students that you teach that to will someday be attending.
Yeah.
Yeah, and you have
It's
something with the residents too. If you know
Yep.
that your students look up to the residents who look up to the attendings, right?
Right.
You have this hierarchy. Use it for good, not evil.
Yeah, yeah. So that also draws attention to this point about it's a slow process. That the teaching of ethics through the traditional routes, if we just have those who are in front of us, it's very slow. And one of the things that I'm always fascinated by is that the students know more about what my partner in the next room does than I do. We really know very little about how our colleagues communicate and practice medicine. We really know very little about that. 5 minutes?
No.
Oh,
Just gonna
okay.
have a question. One of the things I was interested in is something that we've been discussing a lot is pharma policy, how to go ahead and institute some sort of restriction on that. And there is a very respectable firewall policy at the University of Michigan, and yet it's in the list of things that's not covered. And so I was wondering, is that because it's covered at some point in an orientation, or is it more of a don't ask, don't tell? We're not even going to talk to you about pharma, about the things
Right.
that you may get lured into, which I find very disconcerting, if true, because there are going to be a lot of lures after medical school. And not only that, there are going to be a lot of lures that are not necessarily pharmaceutical, but the chasing of money, as in any large research institution, which there are going to be conflicts of interest that can occur. And if you're not taught about conflict of interest, how will you face it? Part two of the question has to do with ethics committees. It's a little distressing that they don't really know about, or they're not taught about ethics committees and how to access them, especially when you would consider that there are many cases in medical school that you'll witness where we want medical students to be willing and able to discuss with their team members, but also, if necessary, to provide for a request for an ethics consultation.
Right. So the point is being made that the policy at University of Michigan is that there are basically no vendor interactions, there are no distribution of pens, there are no textbooks given to students. That's very tightly regulated. That policy, you may know the exact year, David, but it's probably been 5-6 years since it's been implemented. And so you're pointing out that it is one of the topics not routinely taught. Now do remember that we only listed up there things that people said weren't routinely taught, because we wanted to know what are the things that students are systematically or not systematically exposed to, and bear in mind that, again, there were 24 people that were unable to respond for whatever reason. So we don't know for certain that it's not being taught, but it certainly does raise questions. And I think it's not so much of a don't ask, don't tell as it's almost out of mind kind of phenomena, that since there's absolute prohibition of pharmaceutical and device representatives being in the institution, that there really isn't the highly probable random possibility that students would have that experience and someone talk and model about it. And the other one also about the ethics committees, your point about that, certainly we want students to be involved in those things. Though I think, again, it comes back to the previous point raised, would students at Louisville, for example, feel comfortable calling for an ethics consultation? At least in our institution, if you call for an ethics consultation, it's a big deal. And so, would someone say, hey, do you think I'm practicing bad medicine? Are you saying that I'm unethical? This sort of thing. So I think, again, how we help create an environment, how we foster an environment where people feel comfortable doing that is really critical. Yeah. Mm-hmm. Yes, please.
The legal leaders are helping us out. The risk managers and the push toward full disclosure. And, come clean with the family, come clean with your colleagues. If an error is made and it's about outcome occurs, that process of full disclosure is very much approaching being ethical, about
Yep.
being human and making mistakes and all that. So somehow we have to give people permission. We had a grand rounds yesterday morning about medication, egregious handwriting transcribed by a nurse, that's basically 10 times the dose of insulin. Patient is fine. However, it was a really bad error, and it was put up in a blinded fashion. The actual handwriting sample was there, but could have been anybody. And the guy raised his hand and said, I did that. And we actually applauded him for saying that, which I don't know if everybody in the room was applauding. You probably beat him up later, but that kind of permission to come clean and feel bad about it publicly is approaching an ethical
Right.
effort.
So it's interesting because I think you're very right about that. I think there's been a substantive shift from the bad apple theory to, really everyone around here is trying to do their good job. The bad apple theory being that if you just got rid of the bad, unethical person, that everything around this institution would be okay. And the new feeling that, everyone around here is committed, they're trying to do their best. On any given day, you can have a whole cascade of things that go wrong, and it's really when you have the cascade, the doctor doesn't write clearly because they're rushed, they're post-call, they're whatever. Someone distracted them, bumped their elbow while they were getting a drink of their pop, who knows. And the nurse feeling rushed, trying to finish something before the end of her shift, feeling like there might be repercussions, all these different layers, and starting to tease all that out. At Michigan, there has been a pretty proactive approach to safety, and we're moving to a total online order entry process. It started in the OB service, which is where I do my inpatient work. And so it's very interesting because it does set parameters. If you try to give this much insulin, it would say, that's a very large dose of insulin. Are you sure you want to give that? And, it has some safety alerts. And so that ties in, I think, your point about risk management being involved and saying, hey, it costs us a lot of money when these things go wrong. So we can ride that horse. It's also in the patient's best interest. It's in the doctor's best interest. And wherever we can find those convergences where it's really helping everyone out in the same way, that those are very powerful ways. And one of the ways that that's being instituted is by having a systematic order entry program. Is there movement afoot to go to that system, or do you have a electronic order entry system now?
It's supposed to be an EMR integration of the institution over the next 5 years.
Yeah.
It's been, the horizon keeps moving.
Right. It's not easy. I mean, old habits change hard, I believe you had a comment in front?
I just want to know about the hidden curriculum.
Uh-huh.
And how you handle that in your curriculum there. How do you, it strikes me that that's very important in what is actually communicated to students.
Yeah. Uh-huh. Yeah, I mean, the hidden curriculum is there. I think, for example, the case where there's the ER resident that just hates alcoholics and, doesn't want to deal with drug abuse, and, that the comment was made there that the attendings try and intervene and say, look, that's not really the way you should interact with people. But I think it's very hard to patrol that. Well, you just do a better job of selecting who gets in the program. Well, that's fine, but that person is still graduated from medical school, and if they don't come to your program, the problem's not in my backyard, it's now in someone else's backyard. So, at least as an institution, there's, I think, an effort, at least in our department, we have a very extensive process, through interviewing, and the residents have a very significant exposure to other residents and faculty. So that may help us at least somewhat in our department. But I don't know what the answer is to how you address the hidden curriculum, other than, we want to ensure that our students are exposed to the best role models as possible. And I think it also comes to recognizing that the residents especially have a huge impact on student education. And so would it be possible, for example, to find a champion in each residency program, an ethics champion, or how do we get rid of the word ethics? The humanism champion in the residency program to role model for their peers and also for students as much as possible, someone that at a peer level could say, I don't think you really treated so-and-so, I don't know if you had a bad day or what, but, I really felt uncomfortable in terms of how that case was managed, or at least some way to try and confront someone. I think from attending to resident, first of all, you're not going to see it as much, and it's just a lot harder. Do you have any ideas of how to address it?
I was just thinking maybe if you just discuss the issues involved there without trying to assign blame or anything like that. Just say, okay, what were the issues involved here? And there were
Right.
things like not being non-judgmental.
Right.
So it becomes then, it looks like it's a more general discussion, but actually because you just had a patient right there in front of you, it has that realistic quality of being when you're down in the trenches. I always think that's
Right.
sort of what the residents and the students are using as their criteria about whether this really applies to meetings and what
Right.
you encounter in the trenches.
Mhm.
That's why those of us who come from just ethics faculties are not given as much credibility. So maybe just making it explicit at the bedside would be enough to,
Yeah.
or at least bring the consciousness of what the issue is.
Yeah, and so again, it comes the issue being how do you give feedback to someone when I think the fundamental issue there is how do you give feedback to someone when they do something that you think is unethical or not desirable in terms of their behavior, and I think that's hard. I think it's something that we have to do, and my gut response just now was we probably need to do a better job of telling people when they do things well. That it would be easier if we spent more time when we saw residents handling things well in front of students to commend the residents, say, did you see how they did that and this, and they handled that very delicate process in such and such a way, and what I saw was the resident explicitly doing this, folding their hands when the family was really upset, and just pausing and taking time to let them finish ventilating, let the air clear a little bit. We probably don't do enough positive reinforcement, and if we did more positive reinforcement, we might have a little bit more credibility. It might not be as painful when we're making some suggestions. I think part of the problem is that there's this perception that you're either above the line and you're good, or you're below the line and you're bad. And no one wants to be below the line and bad, and if you get feedback from someone who's an ethicist or a teacher talking about ethically related issues, that now you're below the line and you're suboptimal, you're no longer an ethical human being, you're not an ethical doctor anymore. And so how we get around, the good-evil sort of thing that's part of the whole ambiance, I'm not sure. Yeah. Yes?
One more question for you. You mentioned a couple of times that University of Michigan, that in their third and fourth year, the medical students are going to research venues and areas. And how are you blending bioethics from patient to research? Because I see research, I have more complaints on that and more problems with students in those areas than I do in here.
So you're asking more about what we do with ethics teaching around the research, and you said that most of your complaints actually are from students. Is it about students' participation in research, or students feeling as the projects that they're participating are unethical? Or unethical?
It's not they're doing unethical things because their role models, the residents
Right.
are not doing things correctly.
I see.
So
Cutting corners and that sort of thing. Right. Biasing interpretation of data is another one pointed out. Yeah, I think there's an opportunity there. The CTSA is really just starting to get launched now, and that may be a piece to try and integrate more. And again, what we assessed here, and my question back to you, I think I know what your response would be, but what we framed was, in part we're responsible at the medical school level to teach these students their lifetime ethical skills. But what's the limit, and we set the bar as, all right, what do you absolutely have to know by the time you finish medical school so that you can go to the next level? We didn't frame it as so that when you finish medical school or finish X that now you can be an ethical researcher. It was really a lot more clinically focused. So the question would be, do you think that every student ought to categorically be exposed to ethical issues in research. Unequivocally, that every single student graduating from Louisville ought to have that exposure, and then how would you implement it?
I don't think we're as far along as the University of Michigan. I don't think we have as many students going into research as we would. But I know some students like Duke, every one of their students are required to do research.
Right.
And so when you have every one of your students required to do research, they should sometime or another
Yeah.
have good ethics.
So I don't know, maybe, I mean, again, the curriculum time is limited. I mean, you know, the scientific knowledge now is,
I don't think we do one more in isolation.
yeah. Well, I would,
The interactions overlapping.
yeah, I think that's a potential. I wouldn't say that we're ahead of you by any stretch of the imagination, because I don't think we have anything categorically in place around research ethics. There are a series of lectures that all of the students that do research between their first and second year, there's a series of seminars that the students attend. I don't know if there's anything in that addresses research. But that's only students that elect to do summer projects between their first and second year. I'm sure there are other students that are doing it in other ways, but I'm guessing that it's, again, the hidden curriculum in research ethics that's driving most of that. So, you know, maybe having some sort of course or systematic exposure, a selective anyways, about ethical issues in research and presenting some of the really compelling cases. I'm sure you're very well aware, there have been a number of, you know, very egregious incidents, and having some case studies in those could be very helpful, I would think.
Our students here, for the record, are required to do the NIH.
Yeah. Right.
Mine have to do the NIH course for ACS.
Right.
It's very sterile.
Yeah.
And,
Yeah.
you know, you just print out the test after you answer the first time and go back and read and figure out the answer.
So you were raising the NIH online.
But the NIH has a nice animal one, but it's also very sterile. You know, somehow there needs to be a more real discussion.
Right.
City course, answer.
Question back here.
Yeah. I'm sorry.
Yeah, I was wondering, are there any other areas, do you think, in the curriculum or squeezed out of the curriculum that kind of are taught more by example than by, you know, actual didactic lecture? I'm a librarian, and we've had many, many discussions of what medical students and nursing students should know in terms of information technology, in terms of information literacy, and where do you put that in the curriculum? Are there any other areas like that?
You mean in the
get it back in the curriculum.
So you stated you're a librarian and that you're teaching the information technology piece, and is that tied to ethics teaching?
Well,
you're saying as a separate.
It's not taught. That's
It's not
the
taught.
point. It's
Right.
not taught. It's like ethics. Everybody assumes they know how to use the library. They assume they know how
Right.
to find information. Anybody can do that. It doesn't, you know, everybody's ethical. Everybody knows how to behave
Right.
appropriately. And so we suffer the same kind of lack of attention, whereas people don't know the things they need to know in order to be at appropriately information literate position.
Yeah, I guess I'll probably reflect my humanities background here a little bit, but I would like to see particularly more medical anthropology. I think that's an area that doesn't really get enough coverage, and even history, I think, is still relatively short-shrifted. We do have a nice Center for History of Medicine at the University of Michigan, run by Howard Markel, but still, in terms of having systematic time in the curriculum and how much students are, you know, really systematically exposed to that, I think is a whole other question. And I'm sure it's much like Louisville that you have this many great resources in a wonderful institution like this, and to some extent students kind of go out and find their niches. Maybe they're interested in some educational aspect or some humanities aspect, or, you know, IT piece that people may have some interest in or doing research projects in. So I think, again, it does push us to think about, well, what are the things that we feel like every student getting out of here has to get? And then maybe how do we do a better job of saying, well, what are the additional resources we have for people that are interested in other sorts of areas, and how we do teaching around those. And that might relate not just to ethics itself, but to other things. I mean, the information explosion is just, amazing, and the pressures in the medical school, saying we need to add a piece on this, we need to add a piece on this, we need to add a piece on this. Medical ethics is going to continue to have to sort of fight the constant onslaught of pressure on a finite amount of time, because the students aren't going to agree to another year of medical school, and their parents aren't going to agree to it. So we do have time. So reaching time for closure here, I just want to sort of finish with a couple conclusions, if we may. I think the teaching of medical ethics and professionalism does occur randomly, but predictably frequently. In other words, we don't know exactly, we can't pinpoint exactly when it's going to happen, but we know the ethical issues come up, and it's predictable that they're going to come up, and with some level of frequency. And so that's, the good news, that it's there, and there's certainly the teaching material there, and that probably within any institution there are a core number of rotations that are going to have a very significant role in the teaching of ethics and professionalism. It may be due to content area like psychiatry or emergency medicine, or maybe because you have a champion who really says these are really important and takes a special interest in it and becomes that. So we need to identify what those resources are. Role modeling, role modeling, role modeling. This is perceived as the most important educational source for students, including the good, bad, and the ugly. And so, at some level, we have to be, I think, involved if we're going to teach medical ethics effectively, medical ethics and professionalism effectively in medical schools. There should be some involvement of the residents in trying to get them more on board a little bit as role models. Remembering that it's also very contextual, and that we may need to work specifically with courses and clerkships to teach specific ethical issues or professional skills applied to that specific content area, and that we can extend ourselves perhaps by helping them incorporate maybe even just one ethics objective in their talk about cardiac transplant or about cardiac catheterizations or whatever. So, those are really the next steps. What are the role of ethics faculty in teaching topics that are not routinely covered? I mean, I'm guessing that on the list that we put up there of essential topics, that there are probably some of those things that your students aren't routinely exposed to. And there may be some that your ethics faculty as a whole would say, yeah, these are things that we think really everyone ought to learn about. Well, then how do we teach them? And then how would they be taught? And I think a valuable guiding framework are these things that a freshly minted PGY1 really needs to know, because beyond that, then there's the whole residency education piece around medical ethics, and that's probably a whole nother dialogue. So thank you very much for your time today. I appreciate everyone coming out. It's a busy time of year, lots of conferences and teaching and all kinds of things going on, and it truly was a pleasure to have a dialogue with you today.
Thank you very much.
Thank you very much.